Hi, everyone. Today we will be discussing our group project on human papilloma virus prevention. HPV is the most commonly transmitted STI, with the most grave consequence being malignancy, and it is preventable with a vaccine. I'd like to start off with a personal story. There were several factors that resulted in my incomplete HPV vaccination status. This was not resolved until my early 20s. At the age of 11 or 12, I vaguely remember being offered the vaccine, but not being provided much in the way of patient education. Similarly, my mom was insufficiently educated, but she ultimately did consent. So not only did my mom consent to something she knew little about, but the lack of guidance ultimately led to a failure to complete my vaccination series in a timely manner. It wasn't until my early 20s that I was finally able to restart and complete the series. It took a combination of me finally being in a place in my life where I felt I had sufficient agency to ask more questions about my healthcare, and also a provider who allowed for that space. When reflecting back on my experience, I see a few places where earlier intervention could have made a difference. I believe if a provider had taken a few minutes to explain the importance of HPV vaccination, my mom and I would have been more proactive in finishing the series. Members of our group either personally experienced something similar or encountered patients in clinic with comparable stories, and this led to our collective goal of increasing HPV vaccination awareness.
Like Emily mentioned, our main goal was to educate our target group of adolescents and their parents to protect more people from HPV and more successfully prevent cervical cancer. Therefore, our problem statement was the parents and adolescents of family medicine headquarters need higher quality of education on transmission, prevention, and complications of HPV.
So for our evidence, we chose SPA3, which encompasses the San Gabriel Valley. According to Healthy People 2030, pap smears in women in SPA3 were lower than the LA County average. However, cervical cancer death rates were a little bit lower. It was also noted that children ages 0 through 17 had a higher amount of difficulty accessing medical care compared to the LA County average. We did a random needs assessment of 23 community members that went to the family medicine headquarters in Azusa, which is located in the San Gabriel Valley, and found that there was an imbalance of overall awareness of HPV versus understanding of preventative measures. And 78% actually did not perceive an issue with access to medical care. For our intervention approach, we did some preliminary research and found that the parents and children revealed a lack of awareness regarding HPV and access to vaccinations. Upon review of research articles, which include analysis of systemic reviews and multiple studies, it was found that the multi-directional approaches are more successful because they not only target our desired audience of adolescents and young adults, but also the parents and healthcare providers involved in the education. Furthermore, the educational intervention on the topic of cervical cancer, HPV vaccines, and pap smears increased the rate of cervical cancer screenings in our targeted population. Furthermore, the needs assessment revealed a strong preference in the community for in person and pamphlets as part of the intervention.
All of this research, in addition to our experience on clinical rotation, led us to develop a partnership with Dr. Borbor at Family Medicine Headquarters Clinic in Azusa, in which we would provide an in-person education via a group-created CDC-backed infographic to parents, adolescents, and young adults. This partnership allowed us to cater to the spa that we found most in need of the intervention, in addition to providing us a location to have a private clinic-based provider-patient interaction and a facility with access to the Gardasil vaccine. Thirdly, it allowed us to develop a lasting relationship with the clinic in which future PA students will be able to continue the educational intervention. Next slide, please. We use the CDC's HPV fact sheet to create our educational objectives, pre and post test questions, and our original double-sided educational infographic on Canva, with one side in English and the other side in Spanish. Topics covered include the definition of HPV, its prevalence compared to other STIs, its transmission, its symptoms or lack thereof, its complications, most notably cancer, prevention, and information about the vaccine, who should get it, the timing of the vaccines, and where to get it. We went in pairs to deliver the intervention. Once the patient's vitals were taken and they were in a private room, those who were willing to participate were given a pretest. After allowing them time to respond, we went into the room, introduced ourselves as PA students from USC who are working with Dr. B to expand knowledge about HPV, its complications, and the prevention of those potential complications with completing the HPV vaccination series. We then handed them our infographic, allowed them time to review it on their own while one group member scored the pretest. For the sake of the patients and clinic's valuable time and avoiding redundancy, we did not review every aspect of the infographic, only the parts that they marked incorrectly on the pretest. And of course, we reviewed anything that they had questions about. After that discussion, they were immediately given the post-test. We then provided the participants with USC swag of their choosing, provided to us by the admissions office. They also received a copy of the infographic. They were thanked for their time and their participation, and then we allowed the PA students on their rotation to start their visit.
To reiterate, HPV vaccine is recommended for routine vaccination at age 11 or 12 years old, but can be started as early as 9. Thus, our primary target groups were adolescents and young adults ranging from 9 to 26, as well as their parents or family members. Based on our needs assessment, 47.8% of the participants received an education level of high school or less. The average age was 28. We used the small criteria to keep our approximate reading grade level of our pre-post test and infographic at the 8th or 9th grade level. In addition, 52% of our participants also spoke Spanish as their primary language. Therefore, we translated our pre-post test and our intervention to Spanish so that our Spanish-speaking patients would understand the information in order to make well-informed health decisions.
In our needs assessment, 65% identified as Hispanic and 52% spoke Spanish as their primary language. Like Angelica said, we practice cultural humility by translating our information in Spanish for the Hispanic community that makes up a majority of the patient population. We also had either a group member or clinic staff who was fluent in Spanish present at each intervention. We were also curious about the culture and relationship that our patients have with their parents at home. We asked if they've ever heard of HPV, and more than half responded yes. Of those who responded yes, only 7% learned about HPV from home. And when asking our participants if they've ever discussed sexual health with their parents, less than half responded no. We found in our studies that many parents are scared to have this discussion because they fear it will encourage their kids to have sex earlier and corrupt their religious beliefs. Therefore, when educating our patients, it's important to be considerate and respectful of people's religion and culture, while also finding evidence to address the concerns and misconceptions the community might have. It's also important to deliver trauma-informed care, especially to victims of sexual assault. We can do this by creating a safe environment for patients to discuss their sexual health that is free of judgment or shame. We can build trust by ensuring privacy, especially to adolescents who might fear having their information disclosed to parents. But it's also important to be transparent about when you need to report and to provide current and accurate medical information. And lastly, we can empower our patients by giving them the option to stop the intervention at any time. We can also ask them questions about sexual health rather than just simply stating information to them. When it comes to equity and inclusion in SPA 3, only 47% of children aged 11 through 17 received at least one dose of the HPV vaccine in 2018. We found that a barrier is their lack of information and awareness on the vaccination itself. As Kathy mentioned, more than half were not aware of where to obtain the HPV vaccine. As clinicians, we can play a big role by remembering to inform the parents of 11 to 12-year-olds about the vaccine, and other barriers we found were financial costs, stigma, and concerns regarding safety. There are many avenues for us to advocate for better HPV vaccination. In our needs assessment, only 21% heard of HPV through their schools. We can advocate for better STI education, especially on HPV in schools, and even take on leadership roles on school boards. In clinic, we can do a better job of informing and educating our patients on HPV and its vaccine, as we did in our intervention. We can join advocacy organizations that promote sexual health and youth empowerment, and we can speak to our local government about better access to testing and treatment in our community. We can urge them to promote HPV vaccination through community education campaigns.
These are the 7 objectives we had when designing our pre and post test, being able to recognize the transmission, the symptoms, the complications, and etc. For our pre and post test, we received 16 responses. And so for the following charts, you'll be seeing the blue will always represent the correct answer. So with number 1, what is the most common STI in US among the adolescents? Prior to our intervention, only 31% of the participants were able to identify HPV as the correct answer. However, after our intervention, 100% of the participants were able to answer correctly. 2, how is HPV transmitted? Majority already picked the correct answer. So with our intervention, there wasn't much difference. Number 3, which of the following is a common symptom of HPV? Half of our participants picked the correct answer, genital warts, and with our intervention, there was a 40% increase in knowledge. 4, what is the youngest age you can get the first dose of the HPV vaccine? Only 30% of the participants picked the correct answer, but after the intervention, there was a 60 increase in knowledge. Number 5, how many HPV vaccines do you need to be fully vaccinated against HPV? Half of our participants picked the correct answer, and with our intervention, there was a 40% increase in knowledge. 6, what is the long-term complication of HPV? Half of our participants answered correctly, and with our intervention, there was a 25% increase in knowledge. And 7, where can you most likely get the HPV vaccine? Majority did pick the correct answer, so with our intervention, there was a slight increase in knowledge. Number 8, what are the best ways to prevent STIs? More than half chose the correct answer, and with our intervention, there was a 30% increase in knowledge. Number 9, on a scale of 0 to 10, how likely do you think you'll receive the HPV vaccine? Higher the number, the more likely you'll get the vaccine. And you can see in the pretest, there was a variety of answers, anywhere from 1 to 10. With our intervention, you can see that in the post-test, a lot more participants were willing to get the vaccine. And number 10, on a scale of 0 to 10, how confident do you feel about the knowledge of STD? Again, higher the number, the more confident you feel. With our pretest, you can see there was anywhere from 0 to 10. And with our intervention, there was a lot more responses, higher in the number, showing that a lot more people felt confident. And as a result of our intervention, there has been improvements in knowledge in all of our objectives. So all our objectives have been met.
So what can we do to increase HPV awareness and vaccine uptake? On the individual level, we need to start by empowering our patients to take control of their own sexual health. This starts by providing age-appropriate sexual education at every clinical visit, regardless of their current sexual status. Additionally, our role as a provider is crucial to vaccine uptake. Studies have shown that our inadequate recommendation has significantly contributed to suboptimal vaccination rates. Similarly, it is important to implement strategies at the practice level that will ensure dosage completion, such as scheduling subsequent doses and providing printed resources and clinical summaries. And ideally, the vaccination should be offered in all primary care and pediatric clinics. On the community level, providers should work to identify determinants of HPV-related disparities within their own practice communities in order to help guide future interventions. And they should partner with local community health organizations to help facilitate increased access to care for all. It is also important for us to stay up to date on proposed legislation that could affect the health of all of our patients. On the state level, California has just passed a bill which now designates the month of August the HPV Awareness Month. Also, a bill entitled the Prevent HPV Cancers Act of 2021 has currently passed in the House and will now be voted on in the Senate. If passed into law, it would expand funding to educate providers and the public about HPV and its associated cancers, and also aims to increase reimbursement rates. On this note, we advise all medical providers to routinely share their views with their local elected officials. We, as a group, reached out to our Los Angeles representatives to advocate our support for this HPV motion, and we expressed our desire for it to be voted into law, and we urge you to do the same. Contact information for your local legislators can be found on the websites listed here on the slide.
Okay, and so overall, things that went well for our project. For the start, the clinic staff were very eager to participate and made it easy for us to see the patients with ample time prior to the doctor or the clinical students beginning their encounter. The other thing that went well is that the participants themselves were very receptive to our intervention, and it was clear that they took away new knowledge regarding the complications of HPV and the prevention of cervical cancer. Something that we wish we were able to do had we been able to have more time was to provide training to the staff members to give the same intervention so that there would be greater continuity in what we started. Next slide. And so in summary, overall, this project, we did this because we found that the community in the SP3 region falls short in terms of having adequate knowledge of the HPV vaccine and cervical cancer screening, as shown by our initial research, needs assessments results, and pretest results. So for our intervention, which involved speaking with the patients one-on-one, we provided an infographic that explained HPV transmission, complications, and the vaccine. And as a result, our participants significantly improved in their knowledge and willingness to receive the vaccine or give the vaccine to their children, as indicated by our post-test results. And so what we hope to do next is that our project can continue within family medicine headquarters beyond our own capabilities. There's still a lot of work to do to be done on different levels, from the individual to the state and federal level. Next slide, and these are our resources. Thank you so much.